I'm going to hand over to Nicola now, who's going to take us through the next half an hour or so. But while she's talking, I want you to think about some of the things I was talking about earlier on and how those might have played out with the work and the approach that Nicola took to her local piece of work.
So I'm going to talk about how we have been addressing some warranted variation and health inequalities in maternity around particularly women from Black, Asian, minority ethnic background. I'm standing here not telling you that we've got all the answers or that we've completed that work, because that would be totally wrong, but it's actually where we've started and where we still need to go. So I'm just going to start with, prior to COVID-19, there was a body of evidence which was telling us through Embrace. I've just written some notes so I can remember what Embrace is, because I know what it is in my head, but it stands for Mothers and Babies Reducing Risk Through Audits and Confidential Inquiries in the UK. So Embrace looks at a whole range of data and information, and it was telling us before COVID-19 that Black women in this country were 5 times more likely to die than white women in pregnancy. Asian women 2 times more likely, and their babies were more likely to die. And you know, that's shocking, isn't it, in 2021, that we've got such inequity in the outcomes of pregnant women and babies in our country. And the implications for babies are that they're more likely to be born preterm. So I know I've got Lindsay in the room from maternity, so she can put me right with anything, but a pregnancy, you'd normally expect a pregnancy to last 40 weeks, and it might be in between 37 and 42, which would be acceptable. But before then, if babies are born earlier than 37 weeks, they're more likely to need additional feeding, they might need to go into special care, and they might have health problems from being born early. But actually the data, what Embrace is telling us is the difference between Black and Asian and minority ethnic women having babies and white women, it isn't just down to deprivation or where the mothers are born, or where which countries they come from, if they move to the UK. It's something more than that, and we actually don't know what that is, and that's been evaluated and there's research now. But some of it will be down to racism. That has implications for us as a service nationally, but also locally. So the Chief Midwifery Officer wrote to us, to each local maternity system in the country in June last year, and said actually those differences between women who are from a Black, Asian, minority ethnic background and white women were being exacerbated because of COVID. And we were given 4 actions. And one was around making sure that we increase support of those women who are at risk from those groups, making sure that, I'm just going to say, reach out and assure those women with tailored communications. We also knew that they needed to have the vitamin D, and that if there was insufficiency of vitamin D, that caused problems. And that wasn't just for pregnant women from those groups, it was also the wider population, but pregnant women could have an additional dose, and making sure we had to gather the correct data. So we were given these 4 actions in a letter, and we thought, okay, what are we going to do about it? So, as you know, Cumbria is an area of contrast, isn't it? It's beautiful. And those pictures, I've taken those out on my walks and runs, and it's beautiful, isn't it? But we know there's huge inequity. And we also know we've got real deprivation and rural isolation. But actually, what does that mean for those women from a Black, Asian, minority ethnic background? So working with Multicultural Cumbria, they've told us that there's actually around the language barriers, there's risks about not having ability to travel, not understanding what the local authority systems are, what the NHS systems are, they've just moved here, etc., etc. So all those are all the things that we've had to look at over the past year. So for those of you who aren't, don't do maternity as your day job, just thought it'd be helpful for you to know, we have approximately 2,800 births per year in North Cumbria. And women can choose to give birth at the Cumbria Infirmary, at West Cumberland Hospital. We've got a beautiful birth centre at Penrith, or a home birth. So we had 2,800 women who we knew would give birth last year, and that was our cohort of the wider group of women that we were working with. So where did we start? So we decided we'd do a two-phase approach. One was to make sure that we were supporting those women who were pregnant on the week that we got that letter, who were from a Black, Asian, minority ethnic background. And then a more phase 2 approach would be actually doing some co-production work with the MVP. So the MVP stands for Maternity Voices Partnerships. We've got one in West Cumbria and one in North Cumbria, and really strong engagement from service users with co-production. And they've helped us develop the work that we've done. So in June 2020, I'm really ashamed to say that we didn't have a clue how many women were from a Black, Asian, minority background who were pregnant in North Cumbria. And my question to you would be, do you know from the services that you provide either in the local authority or in health or the voluntary sector, how many of the women or patients that you work with or the service users are from that cohort? And out of those numbers, what is the difference of outcomes? So we didn't know. I also had a personal motivation, and one was Jackie Dunkley-Bent, the Chief Midwifery Officer, ran a national webinar after we got the letter with the 4 actions, and I heard 2 ladies speak who had given birth in the beginning of the pandemic, and one of them, she lived in southwest London. I don't know if it's my microphone keeping the noise up. Thank you, that might help better. She lived in southwest London, and she had a second baby at the start of the pandemic, and she was Asian, and she lived in a multicultural community, and she said, I gave birth in a beautiful midwifery-led unit, which sounded amazing, want to go visit it. And she'd given birth there before, but she said I had to prepare to give birth in a white space. And I listened to her, I thought, and this was that on a national webinar, I thought, oh my gum, a white space. You couldn't get a bigger white space in North Cumbria, could you? You know, geographically isolated from many of our communities and very white British. And then I thought, okay, so those women who are going to give birth here, who are from a Black, Asian, minority ethnic background, how must they feel? And my second personal motivation, and I have permission to tell this story, is Lucy and Sabrina. And Lucy is my oldest daughter, she's 26, and her best friend Sabrina is Asian, and she's 26. And they met at secondary school in year 7. And they've gone through school together. They've got similar GCSE results, A-level results. Lucy's a management accountant for NCIC, and Sabrina's a social worker. So both, professional young women. But then if they were both pregnant today, how shocking that Sabrina would potentially have twice the worse outcomes for her and a baby than Lucy. And so that's, my personal motivation really, was listening to the lady about, say, giving birth in a white space, what must that feel like, and for Lucy and Sabrina and all those other women who have potentially got worse outcomes here today. So where did we start? We did a data trawl, and on that day, on the 7th of July 2020, we had 2,389 women who were either pregnant or had given birth recently. And out of them, 88.5% were British, Irish or white other. 2.6% were Black, Asian or minority ethnic background, which is slightly higher than what the last data that we have. We'll get more robust data from the recent census, but the data we have, we look at about 1.5% population, but our pregnant women were 2.6%. And 8.9% had no ethnicity recorded, which actually, when you look at other areas and other parts of the country, that's quite a good score, as in there was no ethnicity filled in. You might go to other places and they might have 20% of ethnicity not recorded. I think I'll be happy one day when that's 0%, and I'm sure my colleagues in maternity will as well. So the question there was, why haven't people recorded it? Was it because it was unknown that, of course, a woman doesn't have to declare their ethnicity? Or was it because our midwives didn't have the confidence to have the conversation with the women at booking to ask them what their ethnicity was, or was it just not filled in? So that was a question that we had to look at. And we decided at phase 1 we'd have some really tailored messages go out to the women who are pregnant from a Black, Asian, minority ethnic background. And some of you may know we have an electronic patient record for maternity, which is called Badgenet. So it's quite easy to put tailored messages out, like push them out. I'm sure the person wants to send them out won't say it's particularly easy, but in my head it's easy. We could get the messages out. We also did lots of work with GPs, actually making sure that they had information as well out in the community. So we soon realised that we weren't going to be able to do this on our own. We couldn't just look at maternity. We had to look at our wider partners to make this work. What I tried to do was sort of thinking, well, I was reading in the news that from a health perspective, it wasn't just pregnant women from a Black, Asian, minority ethnic background had worse outcomes. Because of COVID, it was the wider population. And I kept thinking, oh, was there a group looking at this? But at that point, there wasn't. So we had a look at a range of partners that we could work with, and it was within the health and care system and beyond. And I'll just pick a few out. So the University of Cumbria were brilliant at having a look at embrace data and helping us with the research evaluation. And we worked with Cumbria County Council with some of the work that they were doing. Multicultural Cumbria have been absolutely amazing. They've helped us so much. Our Maternity Voices partners got involved in lots of online groups. So we were mixing cultures, we were having conversations with women. But interestingly, the chief exec of Multicultural Cumbria said to me, do you lot not talk to each other? So I was knocking on her door about maternity, and then she said, oh, I had sexual health on the phone last week asking about for information, learning disabilities a week before, so we really do need to get connected. And I was really conscious of that, but how do we do that and make it really work? And then having conversations with the hospital chaplains. Who do you come across? What women do you talk to? And also talking to our partners in the North East and learning from them. So one of the populations in the North East in one area is a big Jewish population. And Jewish women tend to go into hospital to have their baby with a doula. So a doula is a woman who go in and support them rather than a male partner being there. And of course with COVID, you weren't allowed to take anybody in with you. And from the Jewish population, we suddenly realised that there was an increase in babies being born before arrival, a BBA. If you use the term BBA in front of a midwife or a paramedic, they get really anxious because you don't want a baby to be born unexpectedly out of hospital. So there's an increase in BBAs happened. We work with the Jewish population, and we work with a whole range of voluntary organisations to really, really understand our population. So this is a picture of some work with some women who are refugees in West Cumbria. And our Maternity Voices partnership actually went out and worked with another organisation who worked with those refugees. So I think it's like taking it a step back. We want to, probably what you were saying before, when you rush in and sort things out, actually it takes time, doesn't it? And because of a number of people self-isolating a couple of months ago, I had the privilege of going to meet some of the refugees, and I was given a task to do. I realised actually that task, we're probably 6 months away being able to do that task, but actually have to get the trust and build up that relationship with those women. But great work going on in West Cumbria with Groundwork Trust and the Maternity Voices Partnership. So this is my final slide here, but it's about moving beyond an action plan. You can have all the action plans in the world, but it's about bringing it to life, isn't it? So we're doing that in a number of ways. So it's about challenging mis and ethnicity data. So, for example, in the CCG, we might get reports around serious incidents, not just paternity, but wider health. And if the ethnicity data is missing, I'm saying to my colleague, send it back. and actually ask them to complete the ethnicity field, even if it is not known. We've got to make sure that we have the data and start to understand what's happening here in North Cumbria. We're moving to a model of continuity of carer, where women will be cared by the same midwife or midwife team in antenatally, in labour and postnatally, and actually thinking what are the outcomes for those women who live in a 10% area of deprivation or from a Black, Asian, minority ethnic background. Regionally and nationally, we're now collecting data around women with type 1 diabetes who are offered continuous glucose monitoring, but actually we've added some additional fields in there and saying, actually, if those women are from a Black, Asian, minority ethnic background, what is the outcomes for them? Another example is a Melodies for Mums programme. We've run that in the first place outside London to run that earlier in the year, first place to run it online. We actually had a look at the content with Multicultural Cumbria, and we only actually had one song sung in English in that programme. We used songs from all over the world, so hopefully that made it feel more inclusive to everybody who took part in that programme. This next slide Elaine chose, and I just love it. I love it because it feels like to do something like what we've done, you have to get everybody in the fold, don't you? It isn't just one person. You have to try and gather everybody in, and actually the sheep are all looking in different directions. Within our maternity work, all our partners have got slightly different goals, different visions, but actually if we can bring everybody together, we can make a much bigger difference than working low.
Thanks very much. Thanks, Nicola. I do think she deserves a round of applause. That's great. So we're just going to ask for just a couple of minutes reflection there, not just on the great story and the work that they've been doing, but some of the things we were talking about earlier on. And do they apply? What was it that Nicola did that embedded some of those behaviours? Because actually it came from a direct instruction, didn't it? It was all the things I told you not to do. Somebody from up there sat in a dark room and said, you are going to do these 4 things. Go and do them. Okay? Now, is that what happens to you quite often? I'm sure it is. That's what comes in, and it's another one on the tile. But was there anything that struck you about the way Nicola approached that instruction that was a bit different?
Grasping the current situation and making sure that you've got adequate data that proves where you are currently.
Absolutely. So really understanding that data based on real fact, and when you didn't have the fact, you had to go and find it, and being a bit shocked, and you said ashamed, you couldn't put your fingers on it straight away. So yeah, actually everything you do, building it on reality of actual hard data. What does that mean? Although somebody's written it over there, what does that mean here? That's the first thing. Anything else? Any other observations? Monica?
The passion and her own reason for wanting to make a change.
Great. So those personal stories, those were really the why you wanted to do it, Nicola, I would say. You took something that was a general blanket instruction and suddenly internalised that. And that's something you can do for your teams as well, help them make it their own. Yeah, we've been told we have to do it, but actually is there a deeper reason now why we need to do that? And you could see that was something, the 2 examples being again very passionate views about what she'd heard and how that must make people feel in this area. Any other thoughts? There's another,
Yeah, just thinking quite early on, I think, about that number of stakeholders and getting right down to the women themselves. And so it wasn't just about the professional's voice, it was about how that experience was for those people who were pregnant.
Absolutely. So really genuinely listening to what the customer, if I can use that term, wants, or what the people at the front line are hearing and seeing. And then finally, building on that, I think, did you pick up on that sense of community, that way you had to work across boundaries and barriers, which are still there? You could have done it in your office, Nicola. You could have just sent out another thing that said, and now you are all going to do this. But actually working together across the community, thinking how you might engage this. And for me, the really inspirational bit that came out of Nicola's story was then how you thought, well, that might just be in maternity services, but hey, that's going to be in other services as well. How can I do something or kickstart at least something in other services? So good, I'm hoping that helps just tie it back. You can hear it at one level, where it's just a really interesting story about a great piece of work, fantastic. But I'm asking you now to think slightly differently about why people are doing things, and the way actually you can encourage people to think slightly differently from the, oh no, we've been given another instruction.